Hello again, this is Steve Nyquist with Salient MD, back with another installment of conversation with Dr. Bob Sheppard. We're going to periodically do this. Hopefully you'll find it helpful. My contact information will be available on the thumbnail part of this, and if you want to talk further or ask any further questions, feel free to reach out to me either by email or to my cell phone, that's fine. The topic that we are going to address this time has to do with hospitalist documentation and coding. Dr. Sheppard and I have talked about this on a number of occasions and thought it would be fun for us to spend a little bit of time talking about it this afternoon. And so introduce again Dr. Sheppard, and I'll start asking questions. Dr. Sheppard, somewhere in your journey, you decided to write your own EMR. So my question is, what prompted that? Why would you ever think about writing an EMR?
Yeah, only insanity could be the thing to push that sort of endeavor. It's not that hard though, really, because what I did is I adopted an electronic medical record system in my office before there was a system out there, before there was a commercial product in existence. That was in 1983. So I've had an electronic medical record system since 1983. In 1993, by 1993, I had converted all the other physicians in the county to this same system on their office records, and all of us used it. It was simple, but it worked. It did three things. It did the documentation of the notes, H&P, progress note, discharge summary, etc. And it did the charge capture by the CPT code. And it, in those days, utilized the ICD-9 medical problem system. Later, I converted that to ICD-10, which is no small undertaking. By 1993, I launched it in the local hospital where I was practicing at the time. And for the next decade, I used it, and we ran the entire hospital system with it. So by 2003, when I started the first hospitalist program here and closed my private practice, I took that system and took 4 months off and rewrote the code from scratch so that it was modeled specifically for a hospitalist program. The way a hospitalist works, the way they think, the way they round, the way they carry their devices, etc. This was even before there was such a thing as a local area network. In other words, we didn't have a local area network. The way we printed our notes each day was we carried our laptops around on a cart with a car battery underneath and a local area network module device and a network printer all sitting on the same cart. And so we would roll into a nurse's station, go see the patient, type the note, print it, and put it on the chart physically so the other physicians could see it. So that's how it worked in the early days. Later, then all the printers, of course, became networked printers, so you could print anywhere in the building. We wrote an HL7 interface to interface my EMR program with the hospital's EMR program. So as we created the H&Ps, progress notes, discharge summaries, etc., we were able to automatically upload those to the hospital system. So we had a charge capture system, we had a documentation system, and we had a ICD-9 and 10 coding system all built into the same piece of software. And so that's why I was into the medical record system, because I'd already been in it for many years. By the time we started our hospitalist program, we had more than 2 million records in that system already having been used over the previous 2 decades.
It seems that when new physicians come out of residency, particularly in what I would see as them coming into hospitalist programs, is that well trained clinically, but not particularly well versed in the expectations on CPT assignment and ICD-10 assignment. Um, because that is such an important part of a hospitalist physician's day, and it would seem to me that programs know that. Why do you think that programs don't take more time to prepare physicians for that? And then ultimately, when you find a physician that comes in without that background, how do you train them in it?
Yeah. Well, I think the answer is that these days that actually is a focused effort of the training programs. In other words, that's what I do today is I teach in a hospitalist fellowship training program, and I teach fourth year medical students and family medicine residents. And so we actually do have specific training sessions aimed at that very idea of training them on how to do the documentation, having the history component of a note, having the physical exam component of the note, and then having that component that no doctors, certainly of my age, and many of the younger ones too, don't have, and that is the medical decision-making component of that note. That is how, as you know, Medicare and the Blue Cross payors look at the notes. And so we've got to weave that concept into our notes, and we're beginning now to teach our residents and fellows on how to do that. But for many, many decades, we did not. And so they came out woefully short-skilled.
So but you've had physicians that have come to you that you have not trained, that come from other programs,
Yeah.
that are underprepared for that level of detail about the CPTs and the ICD-10s, and all of a sudden they're seeing patients, doing nice work with that. How do they get trained on the job for those actual the things they need to do to assign CPTs and ICD-10s?
The answer in our program is that I taught them. I sat down for day one, and as I started the onboarding process of bringing a new physician up to speed, part of my job as a director was to teach that person how to do that. If they had no knowledge of it, yeah, it's a tough go, and it's a long, steep learning curve trying to bring them up to speed on that kind of skill set, because as you know, that is a complex arena when you start combining charge capture with CPT coding and with ICD-10 coding, as well as the complexities of creating and maintaining notes from a day-to-day basis.
There is a difference today. You said there was a day when you were in hospital medicine seeing 30, 35 or more patients in a day. Today, no one would ever ask somebody to come in and see that many patients. There is perhaps a difference in documentation expectation today than when you were starting in medicine. How has documentation changed during your time of practice?
Well, I would say this, having been a very early adopter of electronic medical record systems from the early 1980s, electronic medical record systems are the worst thing to have happened to medicine in my 45 years of clinical practice. We do an awful job of creating a medical record that you can bill with, carry forward information for patient care with, and defend ourselves medical legally with. What we have today is cobbled together, templated garbage. I really, really resisted that for many decades of my practice, and finally gave in and began to do some of the things that allowed copy forward, for example, of information from one day's note to the next, until a couple of 3 years ago when I finally just abandoned ship and said, that's it. I'm going to bring my system down. We're no longer going to utilize it. I will not have it railroaded by such a terrible record that is worthless to the patient and worthless to the doctor as well. So I did finally bail on it, but the the majority of the systems that I've worked with, and we've utilized most of them, they are terrible. They allow the physician, or worse, I think, coerce the physician into creating a record that is not useful to anybody, except maybe the payors. And even those, I think, they're less than ideal as well.
So that said, it is the system that we've got. What do we do? How do you function? How does a provider function in that I go from my interaction with the patient to the need to put something in the chart? How do I make sure that I'm doing justice to that, but also hitting those template bells and whistles that are expected of me?
You're right. We've got what we got, and so we got to deal with it. So what are we doing locally in our training program? We are trying to specifically train our physicians to deal with those issues. In other words, we're teaching them in attended courses on how to create the three components of a note, how to carry those forward on a daily basis without replicating on useless garbage, and how to do the CPT and ICD-10 coding, and it is a major uphill battle. It is not easy to do. It's a complicated system, and it's hard to teach. But we got to start somewhere, so that's what we're doing, is trying to start with the residents with that program.
So there would, I assume, be providers that you have dealt with, partners of yours that have always struggled with keeping up with their documentation. It's just a battle to do that, and somehow you've got to cajole or coerce for them to keep up with their documentation. True?
Yes, when we used my electronic medical record system, it was pretty straightforward. I allowed them 24 hours to finish a note and complete it and upload it and sign it. If they didn't do that, they didn't get paid. They could not create another note for another day until they went back and finished that note. So their paycheck was completely 100% dependent upon them completing their note within 24 hours and getting ready for the next day.
So in today's environment, there would be those that would push back. And let's say you were to go to another program, a program that you didn't necessarily author, and you would, let's say, be installed as a medical director of this program, 10, 20 physicians that have had the freedom to let their documentation lapse or go for a period of time without entering charges. How would you address that today?
Even without having control over the electronic medical record system itself, I would still handle it the same way. In other words, I would just simply tell the physicians up front, you're welcome to take as long as you feel like you need to create the medical record. And as soon as you do, I'll pay you.
Conversely, it seems that there may be physicians that enjoy the head down in the computer, doing the documentation, reviewing labs, doing things away from patient floors. Is it possible that there are times where we need to get doctors out of their computer and spend more time with patients and more time with nurses?
Well, you're talking about my arena of medicine. That's how we practiced medicine when I was younger. And today, documentation, I've said often to the medical students and residents, they ask me, what are we going to do today? And I say, well, we're going to see patients till about noon, and then we're going to document what we did that afternoon. Well, it's not quite that bad, but it is close. In other words, I'd say it probably takes 30% of our workday to do and complete that documentation, even when it's done fluidly and efficiently. So it is just simply a part of our system today, and so we've got to learn to adopt it.
So Bedside manner is something that would differ from provider to provider. Everybody's going to have a different view of how they want to do it. Is documentation and coding equally flexible, or are there protocols that need to be established that we all kind of do the same thing, or something close to everybody else in the program, in the group?
That's a tough one because, as you're right, the individual physicians have their own frame of mind about this and how important the documentation is. Some will always do a pretty good job of it. Others are going to shirk that responsibility as much as they can. I think basically the way I would still do it is I would tie the CPT coding and the completion of the notes, those two things, to their pay. In other words, I just simply would not write a paycheck at the end of each month until all that was done and done appropriately. If it's not, sit down with them and go through it until and keep working with them until they get it, till they understand what the components of the documentation notes are. And if they don't understand the CPT coding, keep working on it with them until they are comfortable with it.
So again, just going to pick on that a little bit. So if I've got 20 encounters on Tuesday, and I do not get everything properly documented and in the chart, at the end of the month, you would say that entire shift, you're not going to pay anything for that shift until that is complete.
That is correct. In other words, you could use a paycheck at the end of the month to do that. That's harder for me with a system where we were on a plan where we created the notes and got paid based upon that individual note, added to the next note, added to the next note. It was easier for me to implement it. In other words, if there was ever a day, a 24-hour period, where there were any notes from the previous day that had not been completed mean the notes completed, the CPT coding is completed, and the ICD-10 is completed. If all components of the note are not finalized, they cannot make a note for the following day until that's done. So I never let them get behind more than 24 hours. How you could do that in one of our systems today might be a bit more challenging, but I think ultimately you tie it to pay. When they stop getting a paycheck, they will do it right.
So let's talk about charge capture systems.
Yeah.
Obviously, a new piece from when you started, which is to say that now there are physician mobile charge capture programs out there. When did you see the first one? Are you a fan of them, and how have you used them in your program?
Again, we use my own software to do the charge capture because it was all in one interface, in fact, all in one screen. So the note documentation, the CPT coding capture, and the ICD-10 were all a part of one interface, one window, if you will, in that system. When we abandoned that, when we left my system and went with a commercial system, we did it manually on 3x5 index cards for about a month, and we realized this ain't working. And so obviously we went out there, researched the market, and picked one of the more popular ones that looked like worked, and we've been with it ever since, called Ingenious Med.
Been pleased with that?
Yeah, it's cumbersome and slow, and the download times sometimes in the busy parts of the day are kind of slow and sketchy. Sometimes you have to reboot the system. It's got its quirks, but yes, it's as good a system as I've tried over the years.
And do the physicians carry their mobile device with them and put that information after
Yeah.
they come out of a patient room?
Yes, they either do it with an iPad-style tablet or with their iPhones or some kind of smartphone. So yes, it works fairly well.
Now, a topic that you and I have done some work on together, and that is let's just focus on a CPT code. How much of code assignment is subjective? how much of it is based on the actual acuity of the patient, how much of it is based on what you put in the chart, how much of it is just medical decision making, but how much of this would you say you can quantify and feel pretty good that we're getting, we really know what that level of care should be in that CPT code assignment?
I think the knowledge base about that topic for the average practitioner in hospitalist medicine, particularly those who are younger that are just coming out of training, is poor. For my age physicians, yeah, most of us have finally had to learn it one way or the other. So just to take an example in a history and physical exam note, you got obviously the history component of the note with all the components of the history, the chief complaint, the HPI, the family history, etc. You got all the history components of the note. Then you got the physical exam components of the note. Well, those are pretty straightforward. I think most any physician is accustomed when they come out of training to creating those parts to the note. But as you know, the decision-making part of the note is not something that's been traditionally used very much by physicians, and yet that's the way the payors want to see it. In fact, they demand that it be done that way. And we are still to this day resisting that approach. The medical decision making being how sick is the patient? Why are they sick? How sick are they? What am I doing to fix the problem? What lab tests am I going to order? When am I going to see them again, etc. Those are examples of the medical decision making process. I'm starting heparin because, I'm stopping the Coumadin because, making it clear in the note why you're making the decisions you're making about that particular patient from day to day to day. And that information needs to be updated in every progress note every day from the initial H&P onward.
Do you find that at times physicians that are not as comfortable on that medical decision-making piece spend more time than just talking about stuff that is unnecessary? And so we fill a note thinking that we're hitting what we need to hit, but we're missing the actual objective. And if so, how do you train that?
We actually take our residents through a program now where they actually have to take the information out of Medicare's CPT coding manual and read it and memorize it, so that they actually learn what the components of medical decision making are, so that they can begin to piece those together into the medical record.
So now let's talk about ICD-10 codes.
Okay.
There is an overwhelming number of options out there. The numbers of ICD-10 codes are huge. Doctors are not trained coders. They're supposed to diagnose or be able to understand what's going on in the human body, make decisions about what we need to do to either fix it or find out exactly what it is and then fix it. But these ICD-10 codes have so much complexity to them. How much of that do you want of your physicians to be able to find? How much do you want them to spend the time finding and getting comfortable with them? And how much of that do you say, well, that's the hospital's job. I want to get close, and then I'm going to let the hospital coders clean it up and fix it the way they want it to appear?
Well, from the way the payors, Medicare and Blue Cross in most cases, look at it is they see it as the physician's responsibility. In other words, when somebody else in the billing office bills a note with an ICD-10, CPT, and an ICD-10 coding built into it, even though the physician may not be playing much of a part in creating that document, that part of the documentation, they are ultimately medical legally responsible for that billing. And so my take on that is if the physician's responsible for it, he ought to learn how to basically do it himself. Now, if there are certain glitches that may create and the coder later can clean that up, great. I'm not saying the coder shouldn't have any part to play in it. They can. But I think a physician's got to take ownership of that coding process, both the CPT and the ICD-10. Now, how much of that ICD-10 coding is necessary? Well, depends on who's asking the question. If it's Medicare, they simply want to see the most possible detail there is. The physician wants to take a much 30,000 foot view of that information, and so where we land is most of the time somewhere in between. Let me take an example. We got a patient with congestive heart failure. Well, congestive heart failure is a very low-level code, and when you, in most EMR systems, when you click on the ICD-10 for congestive heart failure, you get a drop-down list that lists things like systolic heart failure acute, systolic heart failure chronic, diastolic heart failure acute, diastolic heart failure chronic, acute on chronic diastolic heart failure, acute on chronic systolic. In other words, just on and on and on. So how much of that is necessary? From Medicare's perspective, the amount that is necessary is the amount that you figured out on the last day of the hospitalization. In other words, the most possible detail you can come up with and still have the documentation validate that code. To me, that is utter foolishness. It is trying to take something that is complex as a medical record and distill it down to 85,000 five-digit numbers. That is great if you're running a coding system. It is crazy if you're trying to take care of patients. But it's what we've got. We're going to have to deal with it. So I think what we should do as physicians is get a basic level of coding in place on the first day, congestive heart failure, if you will. And by the second and third and fourth day, you try to each day increase your coding level to give you more and more detail as your testing and workup brings you back the answers.
Well, Dr. Sheppard, again, we appreciate your time and your wisdom on this. We'll finish for this session. My name again, Steve Nyquist with Salient MD. My contact information, hopefully you will be able to find. If you have any questions, feel free to be in touch, and we'll be back with another session again soon. Thank you.